the understanding of the cause of MS and to develop new treatments. The center is a breakthrough success because of the vision, insight, and flexibility of these extraordinary doctors. Dr. Liliana Amascua at USC, Dr. Rohit Bakshi, Harvard, Dr. Aaron Longbrae, Yale, Dr. Adam Kaplan, MyMD Pharmaceuticals, Dr. Ellen Mowry, Johns Hopkins, Dr. Nancy Sykott, Cedars-Sinai, Dr. Rhonda Voshkul, UCLA, Dr. Emmanuel Walbont, our Race to Erase MS Medical Director and UCSF, Dr. Vijay Yadav, Oregon Health Sciences, Mark Barondis, respected civil trial advocate and co-founding partner of the law firm Miller Barondis LLP. Mr. Barondis has represented many high-profile clients, including award-winning actors, musicians, and sports legends and politicians. And of course, Nancy Davis, founder of the Race to Erase MS, dedicated philanthropist, jewelry and clothing designer, and devoted mother of 5. It is my pleasure to introduce our founder, Nancy Davis, to kick off our panel discussion.
Claudia. Welcome everybody. Last night we had the Race to Erase MS, which was such a huge success. It's really important. Last night was such an amazing night. We had a Tommy Hilfiger fashion show, which was his adaptive line, and it's a line especially for people with disabilities. And Tommy uniquely discovered that there was nobody making these type of clothes, but he did. And it's such a help for people with any type of disability, multiple sclerosis, and all of the others as well. So this fashion show was such an electric, amazing moment to watch. And I'm so grateful to Tommy for doing that. Then we had the most amazing concert you've ever seen with Nile Rodgers. I can't thank Nile enough, and Mark Barondis, because that's actually how we got Nile to come all the way from London last night. I guess he's leaving for Europe today. So he flew in for, 3 hours or 4 hours, however long he was on stage, and he took off. But what a generous soul with the most beautiful music you've ever heard in your life, that everybody of every generation knows every word to every song and danced, and people of all ages, size, shapes, whatever, everybody danced the whole night away. So grateful. Our evening did really well last night, and the whole purpose of an evening like last night is to fund the important research of you doctors who are doing the brilliant work. So we've been doing this for 29 years, and it started for me when I was diagnosed with multiple sclerosis 30 years ago. And at the time, there was no known cause, no cure, no drugs on the market. And more than anything, there was no hope. Today, there's so much hope. We actually have a popular disease, if you want to call a disease popular, and that there's so much happening every single year. And everybody knows that we're going to find a cure. We just need to get there. We have amazing medications on the market for people with relapsing remitting MS, a lot more trouble, coming up with medications for chronic progressive, primary progressive MS. And it is our goal and our vision to reach the needs of every single person who lives with multiple sclerosis to find the best treatments that we can. We're on our way. It's exciting that there's 22 drugs on the market. We have a long ways to go until we accomplish our goal. So thank you all for tuning in today. Thank you for the brilliant work of each and every doctor here, everybody who supports us. We need to keep this going. It's so important. So thank you so much. Thank you, Claudia, for hosting this. You're amazing.
Thank you, Nancy. First on the agenda with MS updates is vaccine responsiveness and MS DMTs. Dr. Aaron Longbrae.
Good morning, everyone. So for the vaccine responsiveness and the COVID-19 outbreak, the first thing that I want to say is that everyone with MS should absolutely get vaccinated against COVID-19. These vaccines are safe and they work. So 100%, if you have MS, you should be vaccinated against COVID-19. There are some differences in terms of how well an MS patient may respond to the vaccination, depending on what kind of medication they're taking for their multiple sclerosis. The good news is that most MS medicines do just fine. So individuals taking most MS medicines have a great response to vaccination, even despite their medications. There are a small number of medications, and those include the B-cell depleting medications, specifically Ocrevus or rituximab. And there are another class of medications called the S1P medication. So that includes Gilenya, Zeposia, Ponvory, and Mayzent. People taking those medications basically make only a half of an immune response to vaccination. Their T cells, that's half of their immune system, those work very well. They have a great response to vaccination. But their B cells have been impacted by their medication, and they're not able to make antibodies. And so people taking the medications that I mentioned will probably not make antibodies after they get vaccinated to COVID-19. That doesn't mean your vaccine did nothing, but it does mean it didn't do quite as much as the person next door to you might have gotten from their vaccine. I will also just mention that there is a little bit of a saving grace here. There is a medication newly released under an emergency use authorization from the FDA. It's called Evusheld. Evusheld is basically man-made antibodies against COVID-19, and people taking the medications that I mentioned who can't make their own antibodies are able to get this Evusheld medication, and that gives you basically that antibody that your body couldn't make by itself. And those man-made antibodies last about 6 months. So I want people to know about that.
Thank you, Dr. Longbraid. Next is COVID-19 updates. Where do we go from here? Dr. Vijay Yadav.
Thanks, Claudia, and thanks, Nancy, for putting such an amazing program last night and also supporting the cause of MS for all these years. So thank you so much for your support.
Thank you.
And also guiding us like along the way and pushing us to do our best all the time. So in terms of like, where we are and where we go from here in terms of COVID, I mean, all of us have lived this pandemic together. We started with the March of 2020 when the pandemic was declared in US, and now we are in May of 2022, and we have seen a huge change in the learning about education about COVID itself, and how MS in particular interacts with COVID. So many things happen so rapidly in like such a short amount of time that it's actually mind-boggling for even us to recognize, the huge impact that this disease has taught us. I would say some of the things that we have learned, and then I think we need to remember going forward as well, that first of all, MS by itself is not an immune compromised state. So that's the first thing to remember, that just because you have MS does not mean that you are, at risk of having COVID complication. The factors and the reason I'm saying all of this is coming from the data that has been collected along with all the registries which were created around the world, which really led us to learn these things very much more easily. So it was effort of all these doctors, all these researchers who put together these registries, and we are able to now tell you what we truly, we believe that, MS is not by itself a problem. So what we also learned during this time is there are certain factors within like any general population or MS, such as age is a factor. If older people are more, they are more prone to get complications due to COVID. People who have higher disability, for example, MS, of course, it can be a disease. It's not every MS patient is disabled, but certain patients with MS are disabled, so they can be at higher risk. So the higher the disability, higher the chances of them having complications. So hence, we have to be cautious. Another thing that we have learned is the effect of comorbidities on COVID. For example, people who are having diseases such as like metabolic syndrome, hypertension, heart disease, diabetes, obesity, they are people who are at generally higher risk of having complications due to COVID. So same thing, if MS patient has these conditions, they will be at higher risk of having COVID complications. So we need to take these patients need to be more cautious about, protecting them from COVID. And as Dr. Longbraid said, we have very good, effective, protective kind of strategies now, vaccine being the number one. So all of us on this panel would strongly, strongly recommend each and every patient with MS to be vaccinated. So that is, I think, the number one thing. And then, of course, we have medications. If you get COVID, there are treatments for COVID that can be given promptly. There is if people who are immune compromised, for example, certain drugs like CD20 therapies, people who are on those therapies, they will need special protection. For example, Evusheld is one mechanism to protect the people. So I think talking to your doctors, listening to their advice, listening to the CDC's advice is, I know it was kind of challenging in the beginning because there were a lot of confusing, conflicting data, but I think now we have learned quite a bit, and we strongly believe that the data which is coming out is solid. So listening to the authorities, listening to your doctors, I think is the best way to protect yourself. And I think we have done much better now, even though we are all seeing surges time to time. Every few months, we all see this surge of, now Omicron was there despite vaccination. So there's frustration, but I feel like despite the frustration, I think we have done very well. I mean, if you really think about 2 years is a huge time. And what we have learned in this last 2 years is like, nothing's short of miracle. I mean, with the vaccination being approved within 10 months of the disease being epidemic, these are like really huge things. So I think the credit goes to all of us together, scientists, physicians, policymakers, government, everybody has come together in this pandemic. And I think with MS, we have done much better with the knowledge that we have created collectively. So, and of course, we'll take more questions, as you guys ask.
Thank you, Dr. Yadav. Relapses versus pseudo relapses. What's going on? Dr. Liliana Amescua.
Thank you very much for having me here. And again, a pleasure again to be here with everyone and Nancy and Curry. So yes, so really important to talk about relapses and go over the differences between what a relapse and a pseudo relapse is. Relapses, first of all, are a way for us as doctors to understand if somebody is having breakthrough disease. And when we say a relapse, we're really talking about new symptoms or worsening symptoms that are lasting longer than 24 hours. In many cases, they start over days and continue on for several weeks. And that is not related to something either external or other internal infections or heat, temperature changes that are contributing to these new worsenings. Certainly really important to talk to your doctor if you're having new symptoms or worsening, so we can better, triage and see if there's an ongoing infection, and for us to assess if there indeed has been breakthrough disease and may require MRIs, as well as treatment with steroids. Now, when we're talking about pseudo relapses, again, we're talking about things that look or symptoms that are looking like a new relapse, but they're not. And again, we're talking about things that are contributing to these symptoms or worsening. For example, urinary tract infections is probably the most common type of infection that we see that can worsen symptoms in patients with multiple sclerosis. But as soon as the urinary tract infection is treated, in many cases, a lot of these symptoms resolve. We can also see worsening, for example, when there is changes in temperature, for example, increased heat. And certainly there's many patients that are heat sensitive. And when when the patient rests or gets cooled down, then in many cases, these symptoms also improve. Certainly with COVID and infections or vaccination, sometimes in patients this symptoms can worsen for about 48 hours, and we have seen that. And certainly the patient can become very worried, but and that's why we're there, right? So whenever you have a new worsening symptoms, we really do want to know, because we want to know, do we need to look for infections, or do we need to go ahead and treat you for an actual relapse? Of course, a relapse, we're really talking about breakthrough disease. And that's important because in many cases that may require a change of your current medication. And for the symptoms, it may require that we look at your symptom management therapy, which is again different than your treatment for your multiple sclerosis.
Thank you, Dr. Amascue. MS treatment, start with conventional or with aggressive treatment? Dr. Ellen Mowry.
Yeah, so being in the MS field is so exciting because there has been such a huge development of disease modifying therapies for relapsing multiple sclerosis. And it's really been a tremendous explosion. And these disease modifying therapies have had an amazing impact on the lives of people living with multiple sclerosis. Now we have greater than 20 different medications available for people with multiple sclerosis. And so when someone is newly diagnosed, it can be really tricky to figure out which is the medication that might be right for me. When we look at how the therapies work in clinical trials, some of them appear stronger than others in terms of what they're impacting, which is the occurrence of relapses that Dr. Mezcua was just talking about, as well as developing new MS lesions or spots on the brain MRI. And so those types of medications are called higher efficacy therapies because they're a little bit stronger. But of course, if you look at the people who are in the trials, some of the people in both arms actually had no further disease activity, even if they were using the mild or more moderate medications that were included in the trials. So for one person to look at a trial and say, well, I understand that the average risk of relapse is lower with this medication, but what about for me? It can be really tricky. And it's especially hard because some of the stronger medications have a bigger impact on immune system functioning. And so that's a lot of concern that people have to think about when they're considering their first medication. There are a lot of really nice data emerging demonstrating that these disease modifying therapies are reducing disability over years and years and decades, that people with MS are becoming less disabled over time. And so now there's a growing interest in studying treatment strategies, specifically understanding if you use one of these stronger medications out of the gate, is it going to impact long-term disability more than starting with the more moderate medication, paying very close attention for the breakthrough disease that Dr. Mezcua talked about, and changing to the stronger medication if it's not working. And so there are actually two ongoing very large clinical trials doing just this. One is called Deliver MS, run out of the Cleveland Clinic, and one is Treat MS that we're running out of Johns Hopkins, but with sites across the United States to answer just this. Is there an appropriate treatment strategy to begin with for people with MS? Is it a one size fits all strategy, or are there some people who would benefit from the stronger medicines out of the gate and others who will do just fine, even if they start with the milder medicines and only change to the stronger ones if it's not working? So we're really thrilled to be doing this study and to answer this question for people living with MS, because it's quite a hard decision to make when you're newly diagnosed.
Thank you, Dr. Mowry. Now on MS research updates, new drugs to prevent relapses and to slow down progression. Dr. Emmanuel Wabon.
Thank you, Claudia, and thank you, Nancy, for putting an amazing show yesterday. We had our scientific symposium, first one of the year yesterday, which was pretty amazing. Lots of sharing between the doctors, and some of the treatments that are in the pipeline were actually discussed yesterday afternoon. We had a little session that was just about what we call investigator-initiated trials at the different sites, which means trials that are not developed by companies, but that are developed by investigators, like some of the people around the table this morning. So although we have, as you heard, more than 20 treatments for preventing relapses in MS now, we actually need more, not because we're greedy, just because some don't work that well, some have side effects, and also what we've not been very good at controlling in terms of MS is the more insidious progression of the disease. So there are treatment trials that are addressing a new mechanism of action, and I would say that they're two large ones right now testing first bone marrow transplant, because until now there were multiple small studies for bone marrow transplant. So it was really hard to know if this was working because the control group was not ideal, or there were major flaw in the methodology of these studies. And because of the risks involved with bone marrow transplant, it's really important to know whether it works better or equally as well as some of the more powerful medications we have that are FDA approved. Another category of medication that is currently being tested, which is a new mechanism of action in the world of MS, is BTK inhibitors. These are medications that have been developed for some B-cell lymphomas, and that are being tested not only for prevention of relapses, but also for prevention of slow progression. And so it's going to be interesting to see whether this new family of medication can really make a good impact in the progression of the disease. And then we have several trials that are trying to focus really on trying to slow down insidious progression. And at that level, we have so I mentioned the BTK inhibitors, but then we have also several attempts using either medications that are already on the market that are, we're trying to repurpose to see whether they are working, slowing down progression of MS. And there are trials out of England looking at cholesterol lowering agents, for example. Within our group, the Center Without Walls, there are at least a couple of trials, one looking at lipoic acid based on promising early phase trials run by OHSU. And then another one for which I got funding from the Department of Defense using N-acetylcysteine. So these are some of the trials that I wanted to mention. There are more, but it would take much longer to talk about that. And this is great news because that means there's really a lot of efforts and lots of focus now to try to help patients with progressive disease.
Thank you, Dr. Waban. Next is new targets and drugs for repair. Dr. Rhonda Bosco.
Hi, so yes, I just want to echo the appreciation for all that Nancy's doing. And last night's event was amazing, especially I think the fashion show with the incredible clothing for people with disabilities. And to that end, focusing on disabilities and actually the progressive form of the disease, I think it's wonderful that we have over 20 drugs for relapsing MS. Has changed the world of MS. But I think the new frontier really is progressive MS and actually disabilities. And in fact, I think repairing these disabilities is the key, the holy grail that remains. Most of the field has focused on immune cells. You've heard a lot about T lymphocytes, B lymphocytes. But I think now we need to realize that, well, these T and B lymphocytes are attacking the brain and the spinal cord. And so I think the field is shifting to this new frontier whereby they're looking at cells in the brain and cells in the spinal cord to see if we can prevent them from dying, prevent them from degenerating. So we need both. We have to prevent or slow down the immune attacks. But in addition, and in combination, we have to make sure that that brain and spinal cord are more resilient and then it can repair. And so I think this is the way forward in a new frontier in combination with the anti-inflammatories to actually repair disabilities. And it's going to be so relevant to progressive patients who really don't have the largest treatment options that the relapsing remitting ones do. Now, just a couple caveats to finish this off. When you think about trying to repair disabilities, you start to think about, well, what are the risks to get more disabilities? And one of them is age. So if we can understand what aging does to the healthy brain, what aging does to MS, and why they go from relapsing remitting to progressive, that will be a key element to discover new treatments to slow that process down. Another, and the last one I'll mention is another second one is, it's really interesting that women get MS more likely, they're more likely to get it. So they're more immune susceptible. But you know what, when men get the disease, they do worse. Worse in what regard? Their disabilities, they progress more rapidly. If we just understood that, we could figure out a way to prevent men from progressing more rapidly. We could figure out in women what's making them more resilient. So I think looking at those keys to modifiers of disabilities is a new frontier.
Thank you, Dr. Bosco. Next is new MRI tools to improve diagnosis. Dr. Nancy Sykott.
Thank you, Claudia. Thank you, Nancy, for an amazing day yesterday and today, and for everything you do. I will just say I've been so impressed with the fact that we've continued to meet and you've continued to fundraise through the pandemic. And I think the drive-ins, we didn't really talk about that too much, but up at the Rose Bowl were brilliant. And I think we've maintained energy and enthusiasm during the pandemic, and it's from your leadership. So thank you for putting us all together and keeping us working. So I think we've heard some really exciting things about how far we've come in MS in terms of our anti-inflammatory therapies and their effect on relapses. And relapses have an MRI correlate, which is new lesions and enhancing lesions. And we've done a really good job of understanding that part of the disease. And I think you've seen that we've have these medications that seem to work really well at suppressing those relapses. So imaging and MRI in particular has been really critical for, first of all, helping us diagnose MS, to assess our new medications. And I think will play a key role as we roll out these new therapies as we're addressing the big issue of progression in MS. So I'm just going to talk about two kinds of biomarkers that we've been working on and that we're excited about. I think will help in this whole process of diagnosing MS and then finding new biomarkers for these treatments that we're going to be developing. So one of the things that's sort of astounding is that MS as a diagnosis is actually sometimes difficult. It's a clinical diagnosis, and we know that it relies on MRI showing those spots that I think everyone who lives with MS knows. They've had MRI scans, they have those white spots. Nancy herself has been through this before. But it turns out that about 20% of individuals who come to an MS clinic with a diagnosis of MS don't actually have MS, they have something else. And this is really important because they shouldn't be put on disease modifying therapies if they don't have MS, but they may have something else that requires a different treatment. And so it turns out that if looking at MRIs and new developments in MRI technology allows us to do a special kind of sequence called the central vein sign that allows us to look at those lesions and really distinguish MS-related lesions from these other non-specific lesions. So this is work that we're doing along with a large consortium of other folks as part of what's called NAMES, that was funded and started because of Nancy's involvement and support. So that's been a real boon to the imaging world. So we're hoping to have validation of this central vein sign and have it incorporated into your standard MRI diagnostic imaging. And this will really help us from the get-go differentiate people who have MS from those who don't, and hopefully diagnose people early who have MS so they can be on an appropriate therapy. So the other area, sort of on the other end of the spectrum, which we've heard a lot of discussion about, which is this progression in MS and the fact that we don't really have effective therapies for that. And one of the things that most people are thinking that may be the reason is that our anti-inflammatory therapies we have right now are working on the periphery, and affecting immune responses there in the bloodstream. But we have evidence now that a lot of this inflammation is going on behind the blood-brain barrier in the brain and the spinal cord. And those anti-inflammatory therapies are not getting there to that site. And we see imaging markers of this in so-called paramagnetic rims lesions and slowly expanding lesions. And so these are lesions that, because of MRI technology and new approaches, we're recognizing that we can see now on clinical scans. We have pathological confirmation, but what we realize is our therapies we have now are not actually targeting this evolution. So one of the excitements about the BTK inhibitors and some of these other therapies is it looks as though they might possibly have an impact on that slowly expanding lesions and that slow smoldering inflammation. And so in order to know if these therapies are working, we need to have a good imaging biomarker. And so our group and others are working on assessing these paramagnetic rims and these as slowly expanding lesions for a readout for some of the therapies. So I'm really excited as we think about the future that I think there's a lot of promise to meet this real unmet need of treating progressive MS. So I want to thank all my colleagues and Nancy for this opportunity.
Thank you, Dr. Sakat. And next we have PET imaging to detect activated microglia, Dr. Rob Bakshi.
Thank you so much. I want to start by congratulating Nancy Davis for 29 amazing years. You are a hero and you are an inspiration, and I'm so glad I've been able to be along with you on this ride.
Thank you.
My focus is on neuroimaging research in MS, and I'm going to speak about a technique called PET imaging, which stands for positron emission tomography. We're now able to use PET in a very fancy way with a new ligand that we can attach to a molecule that will now image inside the brain these cells that we think may be very important for this inflammation that you heard about that is living inside the brain. These cells are called microglia. They're very small cells that our brain uses to help to clean up injuries and maybe take care of viruses and other harmful things that come into our brain. And we believe, unfortunately, that in MS, these microglia get overdriven and actually become harmful. And this may be especially important in later stages of MS when patients get ongoing progression. Indeed, these new therapies that you heard about from Dr. Walbant, the BTK inhibitors, are actually thought to target these microglial cells. Now, using this new PET ligand, there are several centers across the world who are able to image these microglia fairly well with PET imaging. This is going on in Finland. It's going on at Cornell in New York City. It's also being done in Boston at our site and also at Mass General. And the idea here is that we give this ligand to patients. We then do the imaging, and we're able to collect information on what these microglia are doing. The results so far are quite interesting. It shows, for example, that this activation with this ligand is pretty widespread throughout the brain. It's not just in lesions in the white matter at the edge of lesions, as you heard about from Dr. Sakat, but there's also widespread microglial activation in gray matter areas like the thalamus and like the outer part of the brain we call the cerebral cortex. These are critical structures for how the brain functions. We've been able to show, and other investigators have shown, if you have more microglial activation, you're more likely to have more brain atrophy, you're more likely to have more disability. We're now going to be taking these studies into the longitudinal phase to follow this over time. So I'm very excited about this work. It'll give us, number one, more insight into the disease, and number two, a real potential to monitor these new therapies to see if they're actually shutting down the microglia. Thank you.
Thank you, Dr. Bakshi. And next, we have Dr. Adam Kaplan speaking on mind-altering medicines when MS alters your mind, psychedelics, ketamine, and cannabinoids.
Thank you so much. I hope you guys can hear me. When asked to talk about mind-altering drugs, I didn't realize I'd be in a mind-altered state, which is 800 days into having the problem with COVID. I contracted COVID, but let me just launch into this from a remote location, which is safe. Yes, I feel like I'm on the moon a bit. So in terms of psychedelics, it's been around for thousands of years. It was very popular in this country in the 60s. We're talking about things like LSD and magic mushrooms and psilocybin. And essentially these were very popular. They became outlawed in the 70s, but have been rediscovered. What they do is they provide the ability to have people for, after treatment for months to years, they report still having antidepressant effects. Also, there's the potential anti-addiction effects of psychedelic drugs. They increase people's purpose in life and change their personalities to have more openness. The critical thing to know about this drug or these types of drugs is that they change people's perspective. They sort of lead to people, instead of being focused on themselves, now they have a focus that is on the world. They sort of, the part of the mind that focuses on what's called the default mode network on ourselves now gets expanded to a more universal experience. It is also the case that these are done under very specific circumstances, the right setup, which takes 8 to 10 hours. Then it's a 68-hour experience on the drug, and then 68 hours of debriefing afterwards. In terms of ketamine, ketamine is an anesthetic, which actually is able to provide people with a a way of providing an anesthetic that doesn't suppress people's breathing, but at low doses has been found to be very potent as an antidepressant. It works in hours to days, as opposed to most antidepressants that work in days to weeks. So this is a very exciting aspect of it. We don't have enough experience, unfortunately, knowing the long-term use of it, but we know it's very effective in the short term. And finally, there's the cannabinoids. I think many people realize and understand that whether it's medical marijuana or prescription cannabinoids, these help with spasticity in MS and neuropathic pain. Unfortunately, in children and adolescents, it seems to have real cognitive effects. And also in people with MS, they can have significant trouble with memory and processing speed. Finally, there's the concern about with bipolar disorder, marijuana seems to worsen it, as well as if there's psychosis in the family or in the individual. So I think the most interesting part of this is that these antidepressants all seem to have anti-inflammatory effects, and that's true with the psychedelics and ketamine, and that it's a very exciting time, although we are not yet at the place where we have a full understanding of some of these newer drugs like the psychedelics. But thank you for your time and attention.
Thank you, Dr. Kaplan. And next is Living with MS with Mark Barandis.
Thank you, Claudia. I guess those of you that are watching at home are probably wondering, why would you put a lawyer on a dais with a bunch of doctors to bring down the collective IQ of the panel? I just want to say I'm one of those individuals that has MS. I was originally diagnosed with relapsing remitting MS in the year 2000. And now I'm one of those individuals that some of the doctors have spoken about this morning that has progressed, and I now have secondary progressive MS. So when you talk about doing this work to get through the brain barrier and the like, to help those of us that are afflicted with the progressive form of the disease, I'll be your number one cheerleader and hope that you are able to move that forth. I know from my discussions through my amazing team at Johns Hopkins, including Peter Calabresi, who I'm sorry couldn't be here today, Adam, who I saw but couldn't hear. I know the ambition and the drive and the dedication and the perseverance that all of you have towards working towards finding a cure and winning this race. And Nancy, of course, you do as much as you can to facilitate that, and it's extremely important. MS has many faces. I look different than Nancy, and I face different challenges than Nancy faces. I'm different than Claudia and the challenges that she faces. But each one of us do face challenges. And everyone at home, I'm sure that if you're watching this, you're either afflicted with MS or you know or love someone that has it as well. And the challenges that are presented to you and to the family members and your support team are all incredible and very different. But I just want to point out that in the last 22 years, I have seen the miraculous achievements that are taking place towards finding a cure and winning this race. And I have no doubt that with the innovative research, not only of the people on this dais, but also your research assistants and fellow physicians and the like, that will eventually cross that finish line. And it's important to keep, although I couldn't hear anything that Adam said because of an audio issue here, it's important to understand that MS does present not only physical, but emotional challenges as well. The depression is real. That is a form of a disability as well, but it is something that can be treated. And you need to stay optimistic and you need to be driving forward to, so that we can cross that finish line. All patients that have MS live their lives differently. 20 years ago, I never would have thought, well, I'm up here on this dais. How am I going to get off of this elevated panel? But before I stepped up here, I looked to see, okay, how am I getting back down? So these are real things. But I know at some point in the future, I'll be able to get on this panel and I'll jump off of it because of what you guys are doing. So thanks, a heartfelt thanks to all the doctors, to Nancy, and best wishes to everyone for your own good health and success. Thank you.
Thank you, Mark. And now the exciting part, we're doing the lightning round to answer collected questions, and Dr. Wabant is going to help us with that.
Okay, so just a reminder to all the people on the call here, if you have specific questions you'd like to ask, you can write them in the question and answer, and I'll try to handle them as they come. I have a few to get started. So the first one that I'm going to ask to the audience here is, what do you think of HSCT, so basically bone marrow transplant, and would you recommend it for secondary progressive MS? Dr. Lundgren.
I think that there's a lot of intriguing promise with hematopoietic stem cell transplantation. As Dr. Mowry mentioned in her talk, it's still being studied on a research basis, and all of the evidence to date that we have for stem cell transplantation suggests that it will be most effective in those who have relatively early relapsing inflammatory multiple sclerosis. And it's much less convincing to me that it will help secondary progressive MS. And therefore, because of the risks involved in the procedure, I would not recommend it for people with secondary progressive MS, even though I'm very excited to see where the research studies turn up. And I would encourage people considering stem cell transplantation to look into participating in the research studies as opposed to just going and getting it some clinic somewhere that's doing it, so that we can actually answer these questions and have good quality answers about who will this help and who won't it help.
Thank you. So the next question we have is NMES, so electric stimulation, effective to treat moderate to severe hemiparesis caused by multiple sclerosis? Are there any other specific treatments we would recommend? So maybe Dr. Amezcua could answer this question.
This is EMS for treating hemiparesis or motor. I am not aware of any good quality data from using this procedure. Certainly, I think it is being investigated, and there's some anecdotal data from respect to actually more emotional or some dexterity, but that is, we certainly would need to do better studies to better answer that. But if there's anybody else in the panel that knows any more to that data, I'm not sure.
I mean, I think it'll be really interesting as the data progress, though. I remember a colleague, Jen Orthman Murphy, who was a fellow at Johns Hopkins and now is back at Penn, did a really interesting experiment in the mouse version of multiple sclerosis, where, she cut off the whiskers on half of the mouse's face, and whiskers are how mice get their stimulation. And so she did that, and then she gave the mouse version of MS, and she looked to see how recovery occurred on the side of the brain corresponding to the whiskers intact versus whiskers non-intact side, and found that recovery was actually better on the side of the brain getting stimulation. And so you really do wonder, there's a lot of cool work going on in general in neurology for rehabilitation, whether it's through electrical stimulation or other forms of rehab. And I find it really encouraging. And, I often spend a lot of time talking with my patients about exercise and PT and really getting that part of the body working to its fullest potential, because maybe there's something there about how the, brain and the cells that are involved in repair and remyelination are stimulated based on whether it's asked to be used or not.
Yeah, I would like to echo Dr. Mowry's comments. I think it's very promising to think about. We've known for years that exercise, they used to say it was bad. It's not bad. It's good for MS. It does a couple things. You develop redundant pathways to get things done and kind of go around the problem. And the other thing is, we know that the body's not going to repair something that's not active. It's already quiescent. And so the view is to keep those neurons firing and the circuits going. And that's what you're actually going to repair and remyelinate. So I also think theoretically it's interesting.
A question for Dr. Amezcua. When will there be MRI trials or studies on Hispanics where they study their progression compared to that of Caucasian while using a 7T MRI?
Well,
about that.
certainly. Well, first of all, I like to remind everyone that populations such as Black, African Americans, or Hispanic, Latino populations, and Asian populations are really underrepresented in both clinical trials of multiple sclerosis, as well as even just observational studies in multiple sclerosis. Certainly, there's been tremendous efforts in the last, I would say, 5 to 10 years in trying to get these populations more represented. And certainly we're just understanding that these populations and Hispanics as well appear to, be at higher risk of progressing much faster or just having more disability. This is also seen in Black African Americans. We don't know the reasons, but certainly we have some thoughts. And so certainly studies that include these populations are really, really important. For example, even just classic imaging doesn't need to be 7T. We need to better understand sort of their baseline characteristics. We are starting to learn some of their baseline characteristics. There is a trial that is ongoing, which is called the CHIMES trial, that looks at both African American, Blacks, and Hispanic and Latino patients with multiple sclerosis with taking ocrelizumab, and they're followed longitudinally. And we're starting to understand that there are some baseline characteristics that differ compared to what has been seen in the pivotal trials of ocrelizumab. There was data that was presented recently at the American Academy of Neurology, noting, for example, that there appears to be a little bit higher disease burden on MRI from the start, and that they are also quite a much younger population, both in age and also disease duration. So we would love to be able to do more studies, and certainly through hopefully the Race to Erase MS and your efforts, these can be done.
Thank you. So another question here is, do you know of intrathecal treatment of mesenchymal stem cells, neuroprogenitors, to help in any way to slow down progression of MS? And so I'll take this question. It's probably a question related to a study that was published about a year and a half ago. That was a very small study, because we always start with small studies to make sure there's really safety and feasibility of some of these new treatment options for patients. And Dr. Sadiq and his team in New York actually led that study. The study overall showed reasonable safety of the treatment, but was really too small to answer the question of whether it helped. And I don't know whether their plan is to proceed with a larger study, but at this point there was really no clear answer regarding a real benefit. The next question is for Dr. Maury. What is the ideal level of vitamin D a person with MS should have?
Yeah, that's a great question. There have been a lot of studies linking lower levels of vitamin D in observational studies with worse outcomes for people with multiple sclerosis. And in those studies, levels were studied up to about 60 nanograms per milliliter, and there seemed to be an ongoing benefit. And there weren't so many folks above that level who were studied, so we don't really know. Now, interestingly, the clinical trials of vitamin D supplementation in people with MS haven't really borne out a benefit of vitamin D supplementation. And is that because, they're not hitting the right target? Perhaps the benefit that they might have is sort of overwhelmed by the increasing benefit of optimization of disease activity due to the disease modifying therapies. We're not really sure. I know in my own clinic, this sort of negative clinical trials have caused me to focus a little bit more on other aspects of lifestyle management that might be really relevant to the long-term health of the nervous system, such as healthy diet, getting regular exercise, and making sure we get adequate sleep, all of which for all of us are super important for the long-term health of our brain, but that might be even more relevant for people with MS who've had some injuries from prior disease activity.
Thank you. So a question for Dr. Yadav. Patients who are receiving B-cell depleting treatments such as Ocrevus face a major life dilemma. They can continue to be treated with their B-cell depleting agents, but they will have to risk their life by having insufficient B-cell protection and insufficient response to COVID vaccine, for example. As the world now accepts that COVID will become an endemic part of our lives for the indefinite future, continuing to take a B-cell depleting agent is not sustainable to live a healthy social lifestyle. Person with MS need to be able to engage with the public, take public transportation, and for those able to work in public settings. What alternative medications beyond Evusheld are available and are in development that will assist these patients in being better protected and able to live a less restricted life and socially engaging life?
So that's a very relevant question right now. And I think we have struggled actually with this question in the last 2 years. Initial data when we started to come that people who are taking rituximab or other B-cell therapies like ocrelizumab were at slightly higher risk of having worse outcome with COVID, made us pause actually. So we did change, at least I definitely changed my practice. So what we have at least in our clinic, what we started doing is still use the therapy, but use it more cautiously. So for example, you have biomarkers, you have blood biomarkers that you can use to assess how suppressed you are with the therapy. So there are counts which are called CD19 count. These are basically B cells which you can quantify in the blood. There are antibodies which you can, immunoglobulins, so proteins rather, which you can test in the blood, which is IgG, IgM, and they can also be sort of a passive biomarker of the efficacy of these B cells. So I think there's a way that you can balance the use, so you can continue to use a B cell, but also not overuse them. So every 6-month therapy may not be necessary for everybody who's on the B-cell therapy. I think the people who are very active, for example, people who have very active disease, and that's why they're put on B-cell therapy. They are younger people, so they have a higher risk of having continued disease activity. They should definitely continue the B-cell therapy, but under supervision with their doctors and kind of monitor the B-cell responses as well as how they're doing. In general, in addition to the B-cell therapy, if you continue other healthy lifestyle, I think you will be fine. Vaccination definitely is the biggest protective agent against, despite being sort of I won't say suboptimal, little lesser response to the vaccine. The use of booster vaccines in people who are on B-cell therapy, I think that will protect you for sure. So I mean, if you know, or of course, talk to your doctors about the CDC guidelines about how to best use the vaccination, what the booster should be like, for example, what the primary series should look like, what the first booster, second booster should look like. These are very important questions that should be discussed with the doctors. So, I mean, of course, we can't answer all these questions on this panel, but working with your doctor, anybody who's on B-cell therapy, I think they should definitely work with the doctors. Elderly patients who are, who have progressive disease, I would be more cautious. And many of them, they may not need B-cell therapy to be given every 6 months. And either you can delay the treatment by using these biomarker, or some of the patients actually, they continue to decline despite the B-cell therapy. Are they the right one to be on the B-cell therapy? That's a question that, you should be discussing with your doctors and come up with the right approach. But I think we can, with the knowledge that we have, we can still use these therapy very safely.
If I can just comment as well about relative risks. So we are coming to understand that there are some slight increases in risk with B-cell depleting medications in terms of COVID-19, and as well as other more common types of infections. But really, those are very small increases. When you look at the numbers in the clinical trials, when you look at the numbers in observational cohorts, the increases in infections with B-cell medications are small. You have to have thousands of patients to see that there is any increases in risk and infection. And so the relative risks of infection are not zero, but they are small. When, on the other hand, we consider the risks of multiple sclerosis that is unchecked, that's a very large risk. And so I want, just for context, COVID-19 is everywhere. And yes, we're worried about it. We want to take it seriously. We want to protect our patients. But on the other hand, MS is a very meaningful and large risk to you. And our first priority is that the MS is not going to cause you harm. And then we'll worry about the other things. Now, we mentioned Evusheld already. There are other medications that are being developed for pre-COVID prevention. I think we'll continue to see more of those. We're hoping to develop more effective vaccination strategies for people who are on B-cell depletion. But I also want to, agree with Dr. Yadov, but also to temper those concerns by saying that many people can continue to be on B-cell depletion and still live their lives without huge amounts of anxiety that they're going to die from COVID, because most likely they are not.
So I'm going to chime in too, because I think this is a really important topic, and I'm part of a task force for the National MS Society, and we have been giving advice throughout the pandemic. And I think we've come to a point now where, we couldn't hear what Adam had to say, but I think we have to start thinking about the mental health of our patients. And I think that just listening to the way that question was written makes me feel badly that I think we have to find this balance between the fear of getting COVID and then being able to go on and be engaged, because mental health issues are as important as physical health issues. And it's very clear that the virus is not going away, and we're going to have to find ways to be more comfortable with, or figure out what that risk is, right, that we're willing to take. So I think this is our next challenge. And one of the things I would say to the group is what we're missing is some of these outcomes for patients who actually are on B-cell depleters who end up getting COVID. And in our center, we've had over 100 patients, and in particular, since the vaccinations are available in Omicron, none of our patients have been hospitalized. And like, no one wants to get COVID, but they recover if they do happen to get it. And so I think this is the next sort of difficult phase of understanding how we, sort of look at risk and benefit and take into account that life goes on.
A further follow-up is, Dr. Yadov, you mentioned that you kind of have extended the interval between dosing. Our studies and other folks here and elsewhere have also shown that the vaccines may be more effective if given at a certain time in the cycle between infusions, whereby if it's been more than 4 months or so since your prior ocrelizumab infusion, you probably are going to make some antibodies. It's not a definite guarantee, but in addition to having the other side of the immune system working, like Dr. Longbreak mentioned earlier, there may be sort of an optimization where you are sort of pushing some antibodies through, because it's been a while since your infusion. So you can work with your doctor that way too, both with the primary series, 3 doses in people on these therapies, as well as boosters, to try to optimize when's the right time to receive that vaccine.
Thank you. So a little follow-up to this question, and I think we already covered part of that, is could you please give an update on the preliminary results of using Evusheld in relation to COVID prevention? Do protection success rate vary according to MS drugs that the patient is taking? And also, Evusheld was developed during Delta variant surge. Is there any knowledge about how the drug is now performing against the latest COVID variant? So
I'll take a stab at that one. So Evusheld was developed earlier in the pandemic. And so it does have probably better protection against some of the earlier variants. So that would be kind of the original strain through Delta. It seemed to be less effective for Omicron initially. And then after that data came out, the dosing for Evusheld changed to double the dose. And so the higher concentrations of the Evusheld medication in the body should give some protection against Omicron. And then the protection against Omicron, whatever we're at, BA.2, that one seemed to be a little bit better than the original Omicron. And so we do expect that the amount of protection that Evusheld gives probably will vary from strain to strain. And I don't know what it's going to look like for the next strain after Omicron. But on the other hand, Evusheld has been well tolerated to my knowledge. I'll be interested if any of the other docs have different experiences, but we have not had any issues giving Evusheld. We haven't had any complaints really from patients about side effects or serious complications. And so it does seem that it's free protection. It's better than nothing, even if it's not perfect against the most recent variants.
Another aspect I'll discuss briefly is we just completed a study with Mass General in collaboration, and it was the MS patients who get COVID and then don't feel well. There's another option you can do at that point, which is you can give them antibody therapy during the COVID infection. And we reported a series of about 10 or 12 patients who had MS, got the antibody therapy, and got through their COVID very well, were not hospitalized. And then there's also, of course, Paxlovid therapy, which is an antiviral that you can give if you get COVID. So I would say to patients, number one, if you think you're at risk because of your vaccine not being effective, ask your primary doctor or your neurologist about Evusheld therapy before you might get COVID to prevent it. And then secondly, if you get COVID, keep in mind there are therapies available like this.
And if I can just add, most of the post-COVID therapies have a time window. So you need to get them within the first 5 days of your COVID symptoms. So call sooner, not later. Otherwise, we might be too late to give those.
So we have some hot off the press info regarding Evusheld effectiveness, and I'm interested to hear if anyone else here has data as well. So we've given about over 50 of our patients, all on B-cell depleters or other kinds of CellCept, have given them Evusheld, and we now have 3 breakthrough cases. So that's a little bit less than 10%. And I think the original data was 90% effectiveness. So potentially, I guess we're in that window, but it's very early days in terms of the protection is for 6 months. So I think, again, it's another sign that we were talking about how much we've learned during the pandemic. This is sort of science in real time, and we really need to collect this data to have a better sense. So I guess the message is, I think some of my patients thought because they had Evusheld that they would absolutely never, get COVID. It would protect them 100%. Unfortunately, we've learned nothing is 100% during the pandemic, but I think it gives another layer of confidence going out.
How does Evusheld work?
So it's called pre-exposure prophylaxis, and it's essentially giving you man-made antibodies against the virus, against COVID. And so they manufacture antibodies, but as we were discussing, it was an earlier version of the virus. So one of the problems with the B-cell depleters is your antibody response is lower than normal. So this sort of bolsters your antibodies. The problem, of course, is the virus keeps evolving and sort of sneaking by these antibodies that have been developed. So they have to keep updating them potentially.
So is Evusheld trying to redo that to bring in the Omicron or the newer variants?
I think there is work ongoing to try and adjust, but you can imagine, because there's a window where you have to test these things, develop them and test them. And the virus, is moving faster than we can adjust. But great question.
Okay, so the next question, or it was actually some comments from Dr. Kaplan. So maybe Dr. Kaplan, you can make your comment live about the point of mental health and COVID and long COVID having an impact on depression and mental issues.
Thank you, Emmanuel. Unfortunately, the wonderful panel here cannot follow what I'm saying, but the important thing I was just going to mention is that COVID has a profound impact at stimulating the immune system. This long COVID phenomenon is being understood to be much more common than we thought about previously. For example, 50% of people 4 months out from having an infection will in fact have a moderate to severe depression based on a study out of Harvard. How the COVID effects on inflammation affect MS patients is something we don't yet currently understand fully and needs to be really addressed. That's all I wanted to say. Thanks.
Thank you, Dr. Kaplan. And I'm sorry for the panel. We can't all hear you, but at least I can hear you. So I have, so there are a couple of questions that basically are asking about Epstein-Barr virus vaccine. And you've heard recently there was a big splash about EBV and the role of the infection in terms of increasing the risk of MS. So that study actually was just a little piece, a new piece to the puzzle, because we've known that for quite a while actually. And there's at least one trial that is testing whether giving a medication that is preventing multiplication of EBV, whether it has an effect on the course of MS. And I think it's really too early to say. Also, there's really no evidence that having had Epstein-Barr virus infection, which by the age of 20 or 25, 99% of the general population has had. So there's no evidence that once you have MS and you have had EBV infection, that it makes your disease worse. So that some studies are trying to test actually whether treatment targeting EBV are slowing down disease progression, and it's unclear whether they will have an effect. There are other trials that are trying to address, can we prevent EBV using an EBV vaccine, and is an EBV vaccine safe for the general population? And you would have to vaccinate very young children because typically the age range of getting EBV infection is between like 4, 5, and 20. And it's unclear whether that would be safe because EBV may be very important for how your immune system shapes its response to lots of other pathogens. So I have now another question, and maybe Dr. Bakshi and Dr. Saikot can answer. Can you speak about silent progression in relapsing MS being tied to brain volume loss?
Yeah, I'm happy to take that question. There's no doubt in our minds that just measuring lesions in the white matter that we typically do day to day is not sufficient to understand what's happening to our patients. There's an underlying problem that also occurs, which is diffuse loss of brain tissue. We call it brain atrophy. This occurs primarily really in the gray matter, which is where we don't see a lot of the traditional lesions that we measure day to day. And there's a lot of data now to support the fact that a patient with MS may not be having relapses, may not be having even new symptoms, but there's a slow process that's continuing in these other areas of the brain, which largely is reflected by brain volume loss or brain atrophy. And we can see that by looking at MRIs side by side or year by year in our patients. We can see if there's a slow amount of brain atrophy occurring. So I think this is an important feature of MS that we should all consider, not just traditional lesions, in addition to other things we spoke about today, like microglial activation occurring and slowly expanding lesions.
Thank you, Dr. Saikot. Do you want to add anything or?
Well, I think I would just say I agree with everything that Dr. Bakshi has said, but the next phase, of course, would be how can we impact brain atrophy? And we think our therapies indirectly may have an effect on that if we can decrease inflammation. But I think it's increasingly clear that there are these other secondary processes that are going on, and how can we target them? And then to emphasize what Dr. Mowry said, the best neuroprotection that we have currently is aerobic exercise. So if you want to keep your brain healthy, you have to work out at least 3 times a week and start sweating. But that's probably one of the best neuroprotective therapies, and is cheap, relatively speaking, just your gym membership, I guess. So, but I think this is an important and understudied area.
Is it covered by your health insurance?
You know, one more thing which I want to add for neuroprotection is diet, and diet is really important. And I think what we eat is actually what our brain is, made up of. So focusing on diet and very healthy diet. In fact, there's data that Mediterranean diet or even possibly low-fat diet could also be helpful. And Mediterranean diet specifically may be helping with the kind of atrophy protection. So, eating nutrition, like nutritious food is critical in addition to the exercise.
Thank
So
you.
I'd like to add one more thing. I totally agree with what's been said. And I think this, they're not mutually exclusive, looking at the microglial activation around the lesions and also the microglia that we've seen. A lot of people have seen that Dr. Bakshi is referring to this microglial activation occurs also in these other areas of the brain that are not the white matter lesions. And it's critical, it's critical also in aging. It's been shown that there's microglial activation diffusely throughout the brain. And there's also brain atrophy. It's also true in Alzheimer's disease, microglial activation, there's atrophy. And so, I think the MS world can learn a lot from these other neurodegenerative diseases on how to find neuroprotective treatments that target microglia and target brain atrophy.
So there is a question here, and I don't know whether Dr. Bakshi or someone else wants to take it. Matt is asking, seeing that Dr. Howard Weiner is not here today, but he saw a report about Dr. Weiner's recent vaccine to treat Alzheimer's in human trials via nasal spray to remove plaques. Is the thought that this mechanism can be used to clear plaques of MS as well?
Great question. I'm actually on the Data Safety Monitoring Committee for this trial that is going on in Alzheimer's disease at the Brigham. It's very exciting to use an intranasal substance to see if we can limit Alzheimer's disease. There are some commonalities between Alzheimer's and MS. You heard about that from Dr. Voskuil. Microglial activation may be a common theme. I'm not really at liberty to speak about the trial. I've been seeing it day to day what's happening with the trial. But I will say that Dr. Weiner is really committed to working across silos, not just the silos that Nancy's helped to break down with this organization within MS, but have multiple disease state experts speaking to each other, collaborating, whether it be brain tumors, ALS, Parkinson's, Alzheimer's, et cetera. So this is a theme that we believe in strongly at the Brigham.
We just completed a trial of an inhaled therapy, and we're currently cleaning up the data to make sure they're ready for analysis of inhaled insulin as an example of something that's been tested in Alzheimer's and shown some potential benefit. We tested that in people with MS who are having memory troubles. So I actually think the inhaled route of administration of medications is really promising because it can be really hard. We heard earlier to get medications, through the blood into the brain to have their treatment effect. But, medications that are inhaled can kind of go right up through the porous bones, right into the brain tissue, and may realize some benefit, whether it's the ones that we've tested already or future ones. It's really, really an exciting route of administration.
So I see only one question left to answer. So it looks like we're doing a great job at answering questions. Maybe, actually one more. But there was a comment of Dr. Kaplan saying that exercise, diet, and getting depression treated are all important ways to improve MS. And then Dr. Kaplan also put in the chat the link for actually the last question. So the last question is, I am moving to Germany. What would be the best way to find an MS center for my care? And Dr. Kaplan just put a link for you in the chat, so you can check it out. Oh. So I'll, okay, so I am sending that. So that question is yes.
So I might make one comment to that. We've collaborated with the Charité Hospital in Berlin doing various MS studies. They're one of the best in the world. And if they don't know, if they're not going to Berlin specifically, they will know others that are very good. The Germans are very good at doing research and treatment in MS.
Okay, so I am not able to actually cut and paste maybe I can do it. Yeah, so I was going to say that, Adam, you probably have access to the Q&A. So if you could type directly the link in the Q&A, because I'm trying to do it and I'm technically failing. So I hope you'll be able to do much better than me. Okay, so very good. So I do not see any other questions. Oh, actually, I see one last question. Is the microglia PET imaging currently available at Mass General?
The answer is yes. Mass General is one of the sites across the world that has been working on this for many years. We collaborate with them. We have our own site at the Brigham as well. And each site is using slightly different ligands. The broad category that I mentioned, TSPO, PET imaging, refers to a receptor you're trying to bind inside the brain, which shows us the activated microglia. There are many different ways to tag that receptor. You can have a long half-life, kind of fluorinated ligand, which is what we have at the Brigham. You can have a carbon ligand, which is a shorter half-life. And there's other types of ligands that are called first-generation ligands. At Cornell in New York City, they're using the ligand called PK11195. We use a ligand called PBR06, and at Mass General, they use PBR28. So these are technical terms, but we're all driving at the same idea. Hope that answers your question.
Thank you, Dr. Bakshi. So it looks like when we say the last question was written, there's another last question that shows up. So the last question is, can I hold on to hope that there will be a cure soon? And I think that I always love to hear Dr. Weiner answer that question, because what you would say, and I'm going to paraphrase, and hopefully he'll forgive me for doing that, that it depends how you define cure. So if we look at what we've achieved with some of the highly effective medications, they're basically preventing any activity of MS in a fair amount of the patients on those treatments. So that is almost a cure. So that we're getting really closer, and there's really now understanding the cause of MS can help us also identify strategy that would prevent MS. Ultimately, it's even better than a cure. It's basically trying to prevent the disease, but there's still a fair amount of work to be done towards that. Anyone want to add to that?
I'll talk about prevention if I'm allowed to. So sometimes, and I'll say this for the audience, but sometimes we find people who have brain lesions that look like MRI. On MRI, it looks like they have MS, but they've never actually had symptoms of MS. And many of those people probably have a preclinical form of the disease. About half of those who are found to have those lesions then go on to get MS symptoms within 10 years. And those asymptomatic brain lesions can be seen slightly more often, probably in family members of individuals who do have MS. So all that to say, we at Yale are leading a clinical trial to see if giving ocrelizumab in that pre-MS population could prevent MS altogether. And so we're running a placebo-controlled clinical trial of ocrelizumab in individuals who have this radiologic evidence of MS without the clinical symptoms. And so if your family members are interested in finding out more, we have a website called CELLO, CELLO, cellostudy.org. Yale is leading this investigation in partnership with Genentech, the company that makes Ocrevus. And we'll have about 15 sites around the country. And this is just getting up off the ground, so you heard it first here.
Thank you, panelists. You were all wonderful. And thank you, audience, for tuning in. And in conclusion, Nancy Davis.
Thank you. It's so fascinating to listen to everything you guys are doing. I feel so very fortunate to be amongst all of you and to be part of this thing. What our dream was is to find the cause and cure for MS and find treatments. And when I was diagnosed, there was nothing on the market at all. And when we had these first roundtable discussions, there was really little to talk about. It was a lot of pipe dreams, and this might work, that might work. This is going to take 20 years. That's whatever. Here we are, 29 years later, 22 drugs on the market, and it's such a luxury to be having a conversation about, should you do this one or should you do that one? This one works a little better, that one doesn't. So in the scope of things, it's fascinating to look where you guys are going with this. That, definitive, do we have a cure? I believe that for some people, some of the medications on the market are a cure for them. And that's I mean, that's nothing short of a miracle, and it's not by accident, and it's because of all of you and the science. And obviously we need to go a lot further and help every patient that is affected by MS. And I know we're going to get there. And I love the way that you communicate and you put down the traditional barriers that exist in every kind of medical research, and that you're not competitive. You're a group. You join together, and that is, my dream. And I know that's a dream for everybody who has this disease. How do we get there quicker? And congratulations to each and every one of you. I love listening to what you're doing, and thank you for everything. I also want to thank Mark Barandes, who's here and giving his view of what MS is like for him. He's been involved with Race to Race MS since the beginning. I have to thank all of our amazing sponsors and supporters. We would not be here. We wouldn't be able to fund you. We wouldn't have had the most incredible entertainment last night with Nile Rodgers if not for Mark Barandes. He probably isn't talking about that, but he opened up an amazing door, and we had a fabulous evening, which enabled us to raise a lot of funds, which is going to all of you. And how great is that? We get to continue what we're doing. So thank you, Mark. Thank you, each and every one of you. Thank you, Claudia. You have been doing this forever. I met Claudia in Aspen when we had our first event so many years ago, and Claudia is a rock star. And she has helped us put everything together forever. So thank you, Claudia, but thank you, each and every one of you, every bit of science and every different thing you're doing. I never heard about the whiskers on mice before. That was a new one for me. So that's a new thing to think about. I'm wondering if that's for men with mustaches, if that has something to do with it too. Look, I'm not pointing at you. I wonder if that has anything to do with how you feel things. Gosh, there's so many doors that you don't think about, but here we are. We next year is going to be our 30th Race to Race MS, and it's going to have to be a really banner year next year. So everybody, you need to get to work and find a cure by the 30th year. No pressure. And thank you so much.
Thank you, Nancy. Okay, it's a wrap.
Thanks.